Good day and welcome to the United States of Care COVID-19 Tele-Briefing. During the presentation, all lines will be in a listen-only mode. A question-and-answer session will follow the presentation, and instructions for asking questions will be given at that time. Thank you for your attention. I would now like to turn the conference over to Andrew Schwab. Please go ahead, sir.
Thank you, and welcome everybody on behalf of United States of Care. We are excited for you to join our telebriefing with Drs. Mark McClellan, Lisa Fitzpatrick, and Josh Sharfstein. My name is Andrew Schwab, and I'm Director of Policy, Federal Affairs, and Partnerships at United States of Care. Thanks for joining with us for the second of a series of briefings we are administering to bring a critical mass of the tremendous experts and health policy thinkers in the private and public sectors to your virtual ears. I'd like to acknowledge that we have several U.S. of Care team members on the call, including our Executive Director, Emily Barson, and other members of our leadership team. In addition to Hill staff, we have extended invitations to the United States of Care's Entrepreneurs Council, a group of private sector leaders who bring a perspective of innovation to inform United States of Care's work. Over the past 2.5 weeks, in order to support our nation's local, state, and federal officials, U.S. of Care has implemented a pivot in priorities and activities to address the many needs presenting during this crisis. Although we needed to pivot to meet the needs of the moment, this new direction is guided by our mission, which remains to ensure that every single American has access to quality, affordable health care, regardless of health status, social need, or income, and to be a clearinghouse for decision makers. Using our policy expertise, the connections and resources afforded to us via our Board of Directors, Founders Council, Entrepreneurs Council, and Voices of Real Life members, we have worked tirelessly to create federal policy recommendations resulting in policies that provide help across the nation in the immediate term, the future, and to share best operational practices to states as we all do our collective part to slow the spread of this outbreak and serve as a connector to identify areas of biggest need with the people, places, and organizations that can supply those needs. We have created a COVID-19 response hub with useful information and connection-making tools for both state and federal leaders, and we urge you to visit that at our website, which is www.unitedstatesofcare.org/COVID-19. As you begin to think about what a potential phase 4 potential legislative response would look like, we hope to put out recommendations to that end soon. This is our second telebriefing on the COVID-19 pandemic, and we hope to have subsequent ones either weekly or bi-weekly, depending on our capacity. Our esteemed guests, each members of the United States of Care Founders Council, bring different perspectives to our call this afternoon. Dr. Mark McClellan served as both CMS and FDA administrator under President George W. Bush and is currently professor of business, medicine, and policy at Duke University, where he's the founder of the Duke Margolis Center for Health Policy. We are also fortunate to be joined for some extreme local perspective by Dr. Lisa Fitzpatrick, or Dr. Lisa as she likes to be called, who is a CDC-trained medical epidemiologist, board-certified infectious diseases physician, and founder of Promoting Practical Health, a health literacy organization promoting disease prevention through straight talk and storytelling. She's also known for her videos of street interviews about healthcare called Dr. Lisa on the Street, which we encourage each of you to check out. And finally, Dr. Josh Sharfstein, a former secretary of the Maryland Department of Health and Mental Hygiene, Principal Deputy Commissioner of the U.S. Food and Drug Administration, Commissioner of Health for Baltimore City, and currently Vice Dean for Public Health Practice and Community Engagement at Johns Hopkins University. And like many of you, he was also a Hill staffer to former ENC Chairman Henry Waxman of California. Again, welcome to our speakers and our guests on the phone. We will take moderated questions at the end, but right now I would like to turn it over to Dr. Mark McClellan.
Andrew, thanks very much for the introduction, and the Emily and the whole U.S. of Care team. I appreciate what you're doing on trying to improve access to high-quality care and better health for everyone in the country, and this is a time when we really need those efforts. I'm going to talk briefly about a report related to some ongoing work that we're doing at the Duke Margolis Center for Health Policy in collaboration with others, including Johns Hopkins, some of the pandemic experts there, and many of Josh's colleagues, and the American Enterprise Institute with Scott Gottlieb on a path to reopening. I think it's a little bit hard for people to be thinking about that right now when they're looking down this unprecedented surge and this unprecedented pandemic that everyone is appropriately really focusing on to make sure we do as well as possible with the capacity we have to treat the rapidly rising number of cases and severe complications and need for ventilators for patients in different communities around the country. That's what we call phase one of the pandemic, and one where the efforts underway to try to do a better job of matching the need for critical supplies, including ventilators and hospital beds and personal protective equipment and supports for expanded diagnostic testing are really critical, and where we've got a few at least tough weeks ahead. Our paper, though, and our work goes beyond that to focus on what happens next, and alongside the efforts to deal with the current surge, we think it's also important for states and Congress to be thinking about those next steps. So we talk about the pandemic response in phases. It's not quite the same thing as the phases of legislative response that Andrew just referenced. It's more about the state of the epidemic, but each of them comes with steps that states and the federal government need to take to help us move through the pandemic as effectively as possible. Right now in the surge, the most important thing is to get capacity up and continue these extreme physical isolation measures until we see sustained reductions in cases, sustained reductions in hospitalizations, and clear evidence that the hospital and healthcare systems in a community are not being overwhelmed, that we've got sufficient capacity to deal with potential further outbreaks, and that we've also got a better handle on containing community spread of the epidemic. That will also require additional testing. When a few other conditions are met, such as these kinds of circumstances being in place for a couple of weeks and some additional state and local capacity being built up, we think it is reasonable to take steps towards reopening, towards reducing some of the extreme physical isolation and shutdown or lockdown measures that are in place now. These steps include a much more substantial surveillance capacity. That means the availability, much more widespread availability of diagnostic testing, not only for people who are infected with the virus, but also a better understanding of the level of exposure and immunity in each community. That has a significant impact on potential risk of future spread. Building out this capacity is well underway. We've seen a big increase in the availability of tests and innovations in those tests to make them move towards more point of care and rapid testing. Recent FDA emergency approvals of swabs that people can administer themselves to reduce the burden on healthcare providers and conducting the test and all the protective equipment that goes along with that. But this is not going to be really easy to build up, because this can't just be a capacity that's added in a doctor's office or a pharmacy or an urgent care center because of the risk of transmission of COVID-19 and the consequences of transmission being so much higher than, say, a flu or a strep infection. So we're going to need some special ways of delivering these tests in the community, and also special ways of sharing the results of those tests in a timely manner, so that if there is a community-based outbreak, we can respond quickly. And we think that we should be aiming for the point in the not-too-distant future where anyone who has symptoms, anyone who is at elevated risk of COVID-19 because of exposure has ready access to these tests, and the information from those tests is captured to enable quick response to get us out of having to treat whole populations with complications and into good public health surveillance practice of being able to identify cases and trace contacts and take steps in terms of quarantine and isolation to really help contain further outbreaks. Along with that, we talk about the need for rapid progress on therapeutics as well. Vaccines are likely to be coming, but not for some months. In the meantime, there are a number of medical products, immune globulins, potential antiviral drugs, and the like that could have a significant effect on both prophylaxis to help people who are at risk from getting the infection and treatment to help reduce the severity of an infection when it occurs, especially, again, in higher risk individuals. We think those steps are possible in the coming months. And that doesn't mean we're going to get back to normal in what we call phase 2, but it does mean with this increased capacity for surveillance and response and at least somewhat better treatment, that some of the current physical isolation steps could be relaxed, maybe with a new normal that might include many more people wearing masks, something CDC is actively considering recommending right now. Maybe not going back to crowded bars and stadiums, but more opportunities for social interaction and business, but with physical distancing steps, some physical distancing steps still in place, deep cleaning, other steps to contain further outbreaks. And that circumstance we think will last for a while to get there. It's going to take some concerted work by states and local governments and the healthcare community. This is a kind of surveillance capacity that we haven't seen in this country before in terms of the scale of testing needed and the rapidity of acting, of collating that data and acting on responses. I think Josh is working on some of these kinds of surveillance and response capabilities in Maryland and I think perhaps elsewhere around the country too. It's going to require healthcare providers working with public health authorities at the local and national level in new ways, and that is a very important topic for further legislation too, to support this kind of new surveillance and response capacity that we've never had in this country before, along with the capacity to surge if needed, if and when there are further outbreaks. After we make further progress on developing the vaccines, we will get to the point where we can establish more widespread immune protection in our communities. That may start for the vaccines with higher risk individuals with that information that I talked about before, not just on new outbreaks, but on the level of immunity in each region or state. Those two sets of approaches, surveillance plus better immunization technologies from vaccines, should enable lifting the physical distancing restrictions in a much broader way. That's probably not until 2021. We can talk about some of the important steps that are underway to try to accelerate availability of vaccines, such as some of the recent announcements from BARDA and the U.S. Emergency Response Effort in collaboration with vaccine developers to ramp up manufacturing capacity even as current promising vaccines are being tested. But we never want to have this happen again. And if we do things right in terms of the response in the short to medium term, as I've talked about, build out a surveillance capacity with the public health sector and a healthcare sector that's much more focused on population health and prevention and surveillance, we can be prepared better, we think, for future pandemic risks. And we can also lay the foundation for where I know many of you who are involved in healthcare and U.S. Care would like to go, and that's a healthcare system that's much more oriented towards meeting with people where they are, to promoting population health, to detecting health risks earlier, delivering care outside of hospitals in a much more person-centered and community-based approach. We are a long way from that now, but with all of the effort going into the response with the public and private sectors, federal, state, and local pulling together, the private sector pulling together, there's a real opportunity not just for an effective response to this unprecedented pandemic, but also to build a stronger healthcare system for the future.
Great. Thank you, Dr. McClellan. And I'd just like to share that Dr. McClellan does have to leave at 3:30, so probably will not be on for the question and answer session, but our other two experts will be there, and we can also facilitate some questions if you want to email me. And now I'd like to turn it over to Dr. Lisa Fitzpatrick.
Thank you very much. I appreciate the opportunity to be here and talk to folks about what I'm seeing on the ground and at this very challenging and unique time in our history. I see my role today is to remind people about things that most of us think are fairly obvious, and we forget about them and take them for granted, and also to remind you that this epidemic or this pandemic is affecting the underserved in ways that are different than what we're seeing play out on social media and even in the mainstream media. I've spent the last 2 to 3 weeks mostly embedded in the community, either in service or talking to people to see, what's on their mind. Andrew mentioned my video series, Dr. Lisa on the Street, so this is a really great time to be out talking to people to see how this is impacting people in an underserved community. But first, the obvious things that we forget about are the misinformation that's being spread is usually, or what I'm hearing, are usually related to things that are pretty obvious to a lot of us because they're covered in all of the CDC and NIH briefings. They're covered in a lot of the health information that gets posted online and so on. But I'm still hearing the same few questions over and over. How is it spread? Who's at risk, or am I at risk? And how do I know if I have it? People are also asking about whether or not they should get tested because if you remember a few weeks ago, there were athletes or famous people who talked about getting tested, but they didn't have any symptoms. And that's counter to the message we've been giving the public, which is you shouldn't get tested if you have symptoms. And then that transformed to you really shouldn't get tested unless your situation is dire and you need to seek medical attention. And so people are struggling with that message and what seems like a disconnect, because on the one hand we're saying don't get tested, but on the other hand they are seeing people get tested. I'm also hearing a lot of skepticism about the novelty of this virus, which doesn't surprise me. In many underserved communities, there's a lack of trust of the health system and also government. But specifically, I've been engaged in conversations about coronavirus being new because we're calling this the novel coronavirus. And there's also something floating around on social media, maybe you've seen it, with a Lysol can that shows the name coronavirus on the back. And because of that, people are having trouble understanding how this could be a new phenomenon or a new virus if the Lysol can, which has been around for ages, has coronavirus on it. So trying to explain to people the nuances of virology, how viruses behave, and why this virus is unique. But related to that, hearing a lot of conspiracy theories about where this came from, the purpose of it, and I've dealt with conspiracy theories most of my career, particularly when I worked in HIV. And I have an approach for this. I generally listen to what the person has to say, but don't try to dispute or refute what they're saying. So I think just letting them be heard and then moving on is the best way I found to deal with this, because it's very difficult to move people from their positions about this. And so I try to talk about the more germane issues, such as the questions they're asking around spread and how to protect yourself and who's at risk. There's also a lot of misinformation about the cure, if there's a cure out there, if a vaccine's available. If not, why not? Can you use the flu vaccine to treat coronavirus? And so these questions and this confusion is not a surprise, because I spend so much time focused on health literacy and trying to distill this complex information into messages that people can understand. But particularly now with the conversations about compassionate use for what we normally use as a malaria drug, so there's a lot of confusion about, well, if there's a pill to treat it, why aren't we giving it to everyone? So I think there's a lot of work to do around misinformation, and I think we take it for granted that the information is out there. People can access it on the internet. But for me, it's not that simple, because when you really listen to people and understand where the misinformation or the misunderstandings are coming from, you realize they're not really paying attention to the places we all might be looking for sources of information. And I'll just use the last 2 to 3 minutes of my time to talk about what I think is more dire in the underserved population, and that is the social impact this is having in underserved communities. And it's tangible. One of the most tangible ways I'm seeing is with our community partners who focus on food access, food delivery. To give you an example or put it in perspective, one of our partners is Martha's Table, and they normally feed 100 people per session. And now they're feeding well over 300 people or families per session. So they've really called on the community to donate and to volunteer to help them meet the rising demand associated with this. And this increased demand for food, as you might imagine, is naturally coming from the financial impact this is having on this community because of the loss of jobs, loss of wages, and people are really concerned about how they're going to make ends meet. So while we're talking about coronavirus and disease transmission, how to interrupt spread, these aren't necessarily the conversations I'm hearing, or these aren't the things that are foremost on people's minds. They're mostly concerned about the things I talked about. It's stressful not knowing if you'll be able to feed your family. And a woman I spoke to last week said to me, well, this neighborhood is more dangerous than coronavirus, so I'm not really worried about coronavirus. And it just reminded me how much trauma is embedded in a lot of our underserved neighborhoods. And at baseline, there's so much going on, so much scarcity, so much intentional and unintentional violence. So things like this come along, and it doesn't really rise to the level of concern for a lot of people. And that was really eye-opening to me, because even though I'm very accustomed to working in these communities, I was struck by how even something as grave as a pandemic has not really impacted people's psyche the way it has the rest of the country. And I think some of that is linked to the things I was talking about before. The distrust of government. They don't believe a lot of the information they're hearing. and so on. So this, I think this is also linked to the need for us to find ways to better connect with, to build trust, and improve health literacy in these communities. I think I'll just end by telling you about my neighbor, who I talk a lot about my neighbor. But my neighbor is very, I would say he represents every man in a lot of underserved communities. And I asked him, so what do you think about social distancing? Because it's a concern of mine that underserved communities, I volunteer in a shelter, and I know that it's impossible for them to practice social distancing. So I asked him, well, what do you think about it? And he said, well, I don't think it can really work for us because, I was on the bus, and the bus was crowded. Where am I supposed to go? I had to get to where I was going, and I can only get there on the bus. So I think we forget about the impact this can have because we're not seeing these things in the media. We're not hearing from them. And frankly, someone asked me if Black people even get coronavirus. And I wondered why they would think a Black person cannot get coronavirus. And when she explained to me, well, all the people, and this was early in the unfolding of the pandemic, all the people she'd seen who were talked about either having it or having died, because I think she'd just heard the wife of Justin Trudeau was positive. And she said, well, I haven't seen anybody like me who has it. And I think that's changed now. But now they're saying this is an elite virus. And so, well, what do you mean by elite? And the woman said, well, the people who get it, it's mostly rich people. And even in Washington, D.C., our first case we heard about was a clergyman up in Ward 3, which is one of the richest parts of Washington, D.C. So I wanted to share all that context just to remind people that there's a segment of society that we're really not thinking about. I'm not even sure our policies are considering these folks and how we can actually implement public health measures in this environment when there is naturally a lot of crowding, particularly for homeless people, when there's a lot of distrust and skepticism. But frankly, my biggest concern is if people have to be concerned about how they're going to survive. I mean, these are bottom-of-the-pyramid issues people are facing, and that is much more important to them than coronavirus. But I think it's up to us to figure out how to get this on their radar, because even though we haven't heard about a lot of infection or transmission in underserved communities, I think it's bound to happen, and it's going to be a nightmare for us to deal with. So I'll stop there.
Great. Thank you, Dr. Fitzpatrick. And last but not least, Dr. Josh Sharfstein.
Thanks for having me in two great presentations. I'll be maybe brief. I agree with both of the previous speakers. I'll make 2 points. One is right now we have an enormous challenge in this country with the supply chain for personal protective equipment and ventilators. And it would be like an absurd movie if it weren't so tragic what's going on. But states and cities and health systems are pitted against each other. There are all kinds of strange businesses and middle people, brokers, trying to sell things to people. And it's chaos at a time when we really don't need all this extra effort to try to figure out how to get basic supplies to people who need them to protect themselves and save others. And we've had conversations with hospitals, mayors, governors who are just infuriated by what's going on, and it's all unnecessary. If the federal government were able to take over the supply chain, they would not be pitting different people against each other. There could be a clear and transparent way of making sure that the people who are at the front lines are getting the PPE and ventilators that they need. But right now, that is not happening. There's been some great reporting in the Wall Street Journal and elsewhere about the consequences of this, but it is really a self-inflicted wound at the moment. So I thought I would mention that because it has such important federal implications. The second thing, I'd like to switch gears and draw a line between the two previous presentations. The report from the American Enterprise Institute, which a number of Johns Hopkins faculty contributed to, as Mark had mentioned, basically points out that critical to the control of an infectious disease is stopping its spread. That may seem obvious, but just pause for a second. Critical to the control of an infectious disease is stopping its spread. So taking care of people in the hospital saves people's lives, but it doesn't necessarily stop its spread. You have to do both. And the way you stop the spread of an infectious disease is you isolate cases and you quarantine contacts. And so isolating cases means that people don't have a chance to give it to anyone else. And that their contacts who they had contact with before they got isolated then go into quarantine. So if they happen to get it, they won't give it to anyone else. You probably heard about the reproduction number of a virus. It's the number of people each person gives it to. So if the reproduction number is 2, then it goes, the virus spreads 1, 2, 4, 8, 16, 32, 64, et cetera. And you need to get that reproduction number less than 1 in order to stop the spread. And the way you do that is isolation and quarantine. We have almost no capacity in this country to do isolation and quarantine. We do this for, very rare tuberculosis cases. We do it we'll do contact tracing for syphilis and HIV. Most health departments have 1 or 2 people max doing these kinds of things. And when, other countries have had to get this under control, in China, I think it was like 20,000 people they had to bring in one city alone. So we're way away from anywhere near the scale necessary to do something that, the American Enterprise Institute report said was necessary before considering reopening. And so what is isolation quarantine? What does it actually mean? So it means not just doing a test. It's a test plus follow-up. There's follow-up from the test. For some people, it's just getting instructions, and stay isolated. Tell us who your contacts are. We'll reach out to them and tell them to quarantine themselves. That's what some people, for some people. But then for other people, and this gets into Dr. Fitzpatrick's presentation, for other people, it's not so easy. Someone who's homeless, where do they isolate themselves? You got to find a place for them. If you ask somebody to stay home, but they have to leave to get food, it doesn't work. You can't control the spread of the disease. So the issues that she's talking about are core to controlling the spread of the disease. And, if the disease spreads, everyone in society suffers the consequences. So we need to figure out a way in this country to stand up a very robust public health response that both, provides for isolation and quarantine, but also realizes that some people can't just do it. And that they're going to need help. They're going to need resources. In Taiwan, they pay people who are in quarantine. In other places, they're opening hotels for people to go to if they don't feel safe doing this at home. So that's the kind of response that's going to be necessary. And I think, as Congress gets to work on other bills, really thinking about what it needs to stand that up, not just partly more resources for public health departments, but also how do you pay for the infrastructure for major public-private collaborations? We're going to need, hotels, other things to be used for this. How do you really scale up food delivery and make it available everywhere in a city, for example? And also, I think there are real opportunities for public health schools, for example, to play roles really helping to train community health workers and others to be really a public health workforce that gets out and is allowed to respond. So eventually, this is the capacity the country needs to have in order to reopen, because you only feel as confident reopening as you feel confident that you won't have to close right back down the next day. And what keeps you from closing right back down the next day is the ability to stop the spread. And that's really through isolation and quarantine. So that's really an important concept and has a lot of different policy implications. So maybe I'll stop there.
Great. Thank you, Drs. Fitzpatrick and Sharfstein. I believe that Dr. McClellan has left the call, but we would like to go to a question and answer session if the operator could explain how to ask a question.
Thank you. At this time, we will open the floor for questions. If you would like to ask a question, please press the star key followed by the 1 key on your touch-tone phone now. Questions will be taken in the order in which they are received. If at any time you would like to remove yourself from the questioning queue, just press star 2. Again, to ask a question, please press star 1. We'll take our first question from Josh Laurenti of Office of Senator Jeff Merkley.
Hi, yeah, this question is for Dr. Fitzpatrick. So, from the congressional side, we communicate with hundreds of constituents by phone every day, and we're communicating outward on social media. How can congressional offices help bridge the gap to underserved communities and making sure that the right information is out there? Are there specific resources we can be directing people to, or what advice do you have towards that end?
I would use community liaisons if you have people out in the community where they are. I think the information coming from Washington is probably not going to be as effective as it is coming from folks you might have embedded in the community or on the ground, and using those people as messengers to get information out. I think the information just needs to be very basic. The things I talked about, helping people understand that this is a real virus, it is new. Here's how you know, this is when you seek care. So I think you can get all that basic information from the usual sources, CDC, WHO, and so on. But I think it has to be delivered in a familiar environment that's trusted. And if you don't have those people on the ground, then I think you should cultivate those folks. And I'm happy to further advise you about that.
As a reminder, to ask a question, please press star 1. At this time, we have no questions in queue. I'm sorry, we do have one question. It comes from R.T. Ryback of Minneapolis Foundation.
Yes, I wanted to ask about your sense of what communities should be looking at in the blocks around hospitals. We are obviously looking at, as the surge comes, lots going on inside the walls, but what about the periphery around it? What about protecting the community? What about including the community should we have on our mind?
I think this is Josh. The virus is not airborne, so it's unlikely that there's really no risk to the surrounding community of people getting sick from like air coming from the hospital. So I think the main issue is probably the traffic. Right now, the hospitals have generally a lot less traffic overall because so many other services are shut down. But I guess in any individual case, there may be questions that community groups have, maybe about traffic patterns or other things like that that would be best worked out locally. But I don't foresee like there's a fundamental threat to communities that are, like a direct viral threat from the blocks around a hospital.
The only thing I would add is I think there's a lot of confusion in the community when we say this is spread by respiratory droplet and they hear airborne and they want to know, I've had questions, well, how long will it linger in the air before, because I emphasize that when someone sneezes and when explaining why 6 feet and what's so magical about 6 feet, because the droplets gravity will pull the droplets to the ground, well, then they still are concerned. But if it's in the air, and then there's the concern that the droplets will linger in the air. And so I think if you have a platform in which to help people understand this, to reinforce the point that this is not airborne, I think that would help a lot.
Great. Operator, do we have anything in the queue? Star 3.
Star 1 to ask a question. We have no questions at this time.
Okay. All right, I'd like to ask just one last question of Dr. Sharfstein. If you were still the Maryland Department of Health, if you were still there and in charge, what would be your message to Congress on what the kind of buckets that they need to think of for the next phase 3 or 4 legislation they are foreshadowing?
So I think, like I mentioned, one big bucket would be the supply chain. The second big bucket would be paying for treatment. There's a lot of confusion that people have about whether they're covered. Some people may be uninsured at all. The last legislation helped for the uninsured, and for testing, including for the uninsured in theory, but treatment is very important. You don't want people hacking away with a cough at home because they're afraid of the bills that could come. So I think that is very important. So first bucket, supply chain. Second bucket, treatment funding. Third, I would say the public health response. So that's what I was talking about earlier, and really thinking creatively about ways places can scale up the public health response. And fourth, I would definitely put, and these aren't necessarily in rank order, but I would definitely put in the critical need for a strong social safety net to help people who are affected. And I would put both under that. Generally, they're affected by losing their jobs and some of the things that I know have been done. But I think there needs to be a particular push to stand up services to help with isolation and quarantine. I think Congress could really make it clear that that is a special population of interest, because that is the population that we're asking to stay at home really to prevent the spread for everybody else. And when people can't do that, everybody's at risk. And so particularly focusing resources on that, I think, is very important.
All right, operator, do we have any remaining questions?
No, sir. No questions in the queue.
Okay, great. I think we can end then.
Thank you, ladies and gentlemen. This concludes today's call. You may now disconnect.